Right now, if you just go on TikTok, there are literally billions of views under the hashtag narcissist.
Oh, yeah. Billions.
Right. I mean, we are practically living in this golden age of armchair psychology. Like, every bad ex-boyfriend is suddenly labeled a psychopath, and,
Ah,
every demanding boss you have is borderline.
it is everywhere you look. And, I mean, you can totally understand the appeal of it, right?
Yeah, for sure.
Slapping a really clinical-sounding label on someone who treated you badly, it offers this neat, comforting explanation for their behavior. It gives you a sense of control over a chaotic situation.
But what if I told you the international medical community is quietly, basically, tearing up the rule book on what those words actually mean?
They really are.
So, welcome to this deep dive into our sources on personality disorders. Our mission today is to strip away all those pop psychology buzzwords you see online and figure out what these enduring patterns of human behavior actually are. We're going to look at how they fundamentally differ from other mental health struggles and why the latest scientific revolution is completely reshaping how we view human nature itself.
It's a phenomenal time to examine this topic, honestly.
Yeah.
The very ground under these concepts is shifting as we speak.
Really shifting.
Yeah, because psychiatry is moving away from treating these conditions as static, unchangeable character flaws. And they're moving toward a much more nuanced, fluid understanding of how personality actually works.
Okay, let's unpack this. We have to start with the baseline, which is the current DSM-5 definition, because simply having a difficult, prickly, or, I don't know, unusual personality does not mean you have a disorder.
Right, not at all.
The manual defines a personality disorder as an enduring pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture.
And to even qualify for that, it actually has to show up in at least 2 of 4 specific areas. So, your cognition, which is how you interpret yourself and others, your affect, meaning your emotional responses, and then your interpersonal functioning and your impulse control.
But the key word in that whole definition is enduring, right?
That is the key word, yes. For this to cross the clinical threshold, the pattern must be pervasive and inflexible across a really broad range of personal and social situations.
So it's not just a bad day.
No. We are talking about traits that are stable over time, traceable all the way back to adolescence or early adulthood. And this is the crucial hinge here. It must cause genuine impairment or distress.
Right, like are you just eccentric, or is this pattern literally destroying your ability to hold a job or maintain a marriage or just function in society?
Exactly.
But before we can get into the specific types of disorders, we have to establish the fundamental structural difference between a personality disorder and pretty much any other psychiatric condition in the book.
Yeah, this is the ultimate dividing line in psychiatry. It's the concepts of ego-dystonic versus ego-syntonic.
Okay, walk me through that.
So if you have an episodic illness, let's say panic disorder or major depression, you experience those symptoms as foreign. Like, you know you are having a panic attack, you hate the feeling, and you desperately want it to stop.
Because it feels like an attack on you.
Right. The symptom is completely at odds with your sense of self. That is what we call ego-dystonic.
But a personality disorder operates in a completely different universe.
It really does. Because a personality disorder is ego-syntonic.
Meaning it aligns with their ego.
Yes. To the person experiencing it, these rigid patterns, these intense reactions, they just feel like, well, who I am.
Wow.
The individual rarely experiences their own behavior as a symptom. They don't walk into a room and think, oh, my interpersonal functioning is currently impaired.
Right, they just think everyone else is annoying.
Exactly. Instead, it's usually the people around them who experience the distress.
I like to think about it like a pair of glasses. Having a personality is just like wearing a standard pair of glasses that helps you see the world.
Okay, I like that.
But having a personality disorder is like having a pair of glasses with a thick, heavily distorted prescription permanently glued to your face.
Yes, glued to your face.
Because they've been there so long, you don't realize your vision is warped. You just assume the world actually looks that way. Everyone else looks blurry, so you assume they're the ones out of focus.
That is a phenomenal way to visualize it. The distortion is built into the lens itself.
Wait, I'm stuck on this glasses analogy, though.
Oh, why?
If I don't know my glasses are broken and I think everyone else is the problem, I'm never going to voluntarily walk into a therapist's office and say, hey, please fix my personality. So how are these people actually getting diagnosed?
Well, they get diagnosed because of the downstream fallout.
The fallout.
Yeah, they show up in a therapist's office or an emergency room because their marriage just violently collapsed. or they were fired from their third job in a row for insubordination, or they're in the middle of a severe life crisis.
So they hit rock bottom.
Pretty much. This profound asymmetry, where the patient initially sees the external world as the problem rather than their core traits, is exactly what makes personality disorders notoriously difficult to treat.
It makes me think of the distinction our sources draw between OCD and OCPD to, perfectly illustrate this divide, because people confuse these two all the time simply because they share an acronym.
Well, constantly. But structurally, they are complete opposites.
Right.
OCD, obsessive-compulsive disorder, involves intrusive thoughts and compulsions. The person hates them.
Ego dystonic.
Exactly. They know that washing their hands 50 times a day is excessive, but the internal anxiety forces them to do it.
Whereas OCPD, obsessive-compulsive personality disorder, is a pervasive style of rigid perfectionism. It's an obsession with rules, order, and control.
Yes. Let's put this in a real-world context. Someone with OCD is agonizing over internal fears. Someone with OCPD is having an absolute meltdown at their roommate because the dishwasher was loaded inefficiently.
Oh, man, I know people like that.
Right. The person with OCPD doesn't hate their rigidity. They think it's just how things should be done. They're profoundly annoyed that you aren't following their perfectly optimized dishwasher protocol. That's egosyntonic.
Which is a dynamic that has baffled the medical establishment for centuries.
Truly.
So, before we had modern diagnostic manuals, how did doctors even begin to classify someone who was destroying their life or the lives of others, but wasn't actually delusional?
It was a massive medical mystery. You really have to go all the way back to 1801.
1801, wow.
Yeah. A French physician named Philippe Pinel was observing patients in asylums who were highly impulsive, reckless, and violent. But their intellect was perfectly intact.
So they knew what they were doing.
Yes, they didn't have hallucinations or delusions. This completely broke the medical models of the time, which assumed that irrational behavior was always caused by a break with reality.
He called it manie sans délire, right, which translates to mania without delirium.
Exactly. It was the first real clinical attempt to describe what we would now call antisocial or psychopathic traits. And as we move through the 19th century, this concept morphed into a heavily stigmatized label called moral insanity. Doctors recognized the person's reasoning was fine, but their conduct was persistently, undeniably destructive.
But the architecture of what we use today really didn't start taking shape until the 20th century.
Right. In 1923, German psychiatrist Kurt Schneider proposed 10 distinct abnormal personality types, which kind of moved us closer to a medical classification.
And then came Hervey Cleckley.
Yes, in 1941, an American psychiatrist named Hervey Cleckley published a landmark book called The Mask of Sanity. He outlined psychopathy, describing these charming, highly intelligent individuals who totally lacked remorse, shame, or loyalty.
Which became the bedrock for how we assess psychopathic traits today. But looking at our sources, the real structural earthquake in modern psychiatry happened in 1980 with the publication of the DSM-3.
That was a monumental shift. A psychologist named Theodore Millon pushed for a multi-axial diagnostic system.
Multi-axial.
Yeah, so axis, I was reserved for episodic conditions, things like clinical depression, schizophrenia, or panic attacks. But Axis II was specifically carved out as a separate category solely for lifelong personality disorders.
He literally separated their diagnoses from the rest of mental illness.
He did. And if we connect this to the bigger picture, while that literal Axis system was retired when the DSM-5 came out in 2013, the conceptual boundary it created is still the foundation of modern psychiatry.
The idea of enduring traits versus temporary illnesses.
Fundamentally, yes. It still organizes how professionals think today.
I have to challenge the historical impact of that axis split, though.
Go for it.
When you isolate a group of patients onto their own separate lifelong axis, doesn't that accidentally weaponize the diagnosis?
What do you mean?
Well, it feels like you're branding them as permanently broken. You're essentially telling the medical community, people are sick and can be cured, but axis II people just are this way forever.
Oh, yeah. That is a very dark, very real risk. And history proves your point entirely. There is a grim reality of diagnostic misuse when it comes to labeling someone's core character as a disorder.
I can only imagine.
The sources explicitly note how psychopathic personality and related diagnoses were used as pseudo-medical justification in Nazi Germany's T4 program in the 1930s and 40s.
God, that is terrifying.
It is. The state deemed certain people socially undesirable, applied a personality diagnosis, and used it to justify institutionalizing or sterilizing them.
Wow.
It's a chilling historical reminder, When you categorize a human being's fundamental traits as a disease, that label can easily be weaponized by the state or the culture, rather than used as a tool for healing.
That history of weaponizing labels is exactly why the field is currently experiencing its biggest theoretical fight in decades. The medical community is finally realizing that human beings simply do not fit into neat little diagnostic boxes.
The traditional model is heavily flawed. Like the DSM-5 traditionally organizes 10 personality disorders into 3 distinct clusters.
Right, the A, B, and C clusters.
Yes. You have cluster A, which is the odd or eccentric types like paranoid or schizotypal. Cluster B is the dramatic, emotional, or erratic types. That's your antisocial, borderline histrionic, and narcissistic.
The ones we see on TikTok.
Exactly. And cluster C is the anxious or fearful types, like avoidant or dependent.
But according to our sources, the major clinical embarrassment of this system is the massive diagnostic overlap.
The borders between these disorders are entirely porous. Like a patient might check 5 symptomatic boxes for borderline, 4 for narcissistic, and 3 for dependent.
So they just get diagnosed with all 3.
Yeah, they end up with 3 different diagnoses
Mhm.
when they really just have one highly complex personality structure.
Think about your own personality for a second. You probably don't fit perfectly into one archetype. You have a mix of traits depending on the situation.
Of course.
Here's where it gets really interesting, though. The traditional categorical model is like painting with only 10 fixed primary colors. You have narcissism red and avoidant blue. If someone's behavior doesn't perfectly match the paint chip, the system struggles to classify them.
Which is why the scientific revolution happening right now is a total shift from categorical to dimensional thinking.
A dimensional approach.
Yeah, we are moving toward a model that acts more like a digital color slider. It's infinitely messier to calculate, but far more accurate to actual human nature. In the DSM-5, they actually included an alternative model for personality disorders, the AMPD.
How does that actually work in practice, though?
Instead of checking boxes for a specific named disorder, a clinician uses a severity continuum. First, they measure how impaired the person is in their identity and relationships.
Okay.
Then they map the person's personality across 5 broad trait domains: negative affectivity, detachment, antagonism, disinhibition, and psychoticism.
Which actually closely mirrors the big 5 personality traits used in mainstream non-clinical psychology.
Exactly. It's treating them like extreme variations of normal human traits rather than alien diseases.
But the real bombshell in our sources came in 2019 from the World Health Organization.
The ICD-11,
Yeah.
the International Diagnostic Manual, completely dropped nearly all of the old named categories.
Wait, they just dropped them.
They simply do not exist in that manual anymore. They replace them with a single diagnosis called personality disorder, which is then rated by severity, mild, moderate, or severe, and described with specific trait qualifiers.
So if you live outside the US or you're operating under the WHO guidelines, those 10 famous labels that TikTok is obsessed with essentially don't exist anymore as discrete buckets. The definition is a live, moving target.
Right. And to bring this incredibly complex dimensional debate down to earth, we need to look at how these diagnostic struggles play out in the real world.
Yes, let's do that.
Let's look at how traits function in a boardroom versus how they function in the criminal justice system.
Which brings up a massive exam trap in psychology classes. Antisocial personality disorder versus psychopathy. Pop culture uses them interchangeably, but they measure entirely different things.
They do. ASPD is an official behavioral diagnosis in the DSM. The criteria are focused on observable actions: violating the rights of others, deceit, impulsivity, irritability, and reckless disregard for safety.
But psychopathy is a narrower trait construct, right?
Yes.
It's typically measured by Robert Hare's PCLR checklist, which goes beyond just behavior and weighs interpersonal and affective traits. Things like glib charm, grandiosity, shallow emotions, and a profound, chilling lack of empathy.
Meaning someone with ASPD might get into bar fights, steal cars, and end up in prison, but they don't necessarily have that charming, manipulative, cold-blooded layer of the psychopath.
Right.
And frankly, many people with elevated psychopathic traits never encounter the criminal justice system at all.
They just end up in middle management.
Literally. There was a fascinating piece of research from 2010 called Corporate Psychopathy, which was popularized in the book Snakes in Suits.
Great title.
Right. They assessed over 200 corporate professionals and found a meaningfully higher rate of elevated psychopathic traits in that group than in the general population.
I mean, think about the mechanics of that. Traits like ruthlessness, superficial charm, and a complete lack of empathy are highly rewarded in a cutthroat business setting.
Exactly.
If you need to fire 500 people before lunch and sleep perfectly fine that night, a lack of empathy is a competitive advantage.
It's a perfect example of a dimensional trait mapping onto real life, adapting to the environment.
Yeah.
Another incredible case study in our sources is narcissistic personality disorder, which sparked a literal theoretical civil war between two towering psychoanalysts in the 1970s.
Otto Kernberg and Heinz Kohut.
Yes.
They spent years arguing publicly about where narcissistic grandiosity actually comes from, and their debate fundamentally changes how you would treat the condition.
Right. So Kernberg argued that grandiosity was a defensive mask. He believed it was an elaborate fortress built to hide deep underlying rage, envy, and a profound sense of early childhood deprivation.
So they're hiding.
In his view, yeah, the narcissist acts larger than life, specifically to protect an incredibly fragile core from being exposed.
But Kohut looked at the exact same patients and saw a completely different mechanism. He argued it was a developmental arrest.
Yes.
He believed these individuals were stuck at a normal early childhood stage of grandiosity because their caregivers never provided the proper empathic mirroring to help them grow out of it.
So Kohut concluded the right treatment wasn't confronting their grandiosity, which is what Kernberg did, but rather offering them that missing empathic mirroring in therapy to help them finally mature past that stage.
I have to push back on Kohut's view, though.
Oh.
If a narcissist is running around destroying their spouse's self-esteem and acting completely superior to everyone at work, doesn't a therapist offering empathic mirroring risk just feeding their massive ego?
Well,
Aren't you just validating their destructive behavior toward everyone else?
it's a very common critique of Kohut's method. But there is a deep clinical nuance here. Developmental mirroring does not mean indulging bad behavior or agreeing that the patient is inherently superior to others.
What does it mean, then?
It means validating the underlying emotional need, the desperate, unmet childhood desire to be seen and valued.
I see.
By mirroring that core need, the therapist gently helps the patient build a more realistic, stable sense of self, one that doesn't require crushing other people to maintain its shape.
Okay, that makes more sense. We've looked at how some of these traits, like psychopathy in the boardroom or narcissism in a marriage, turn outward and damage others.
Right.
But what happens when the distortion turns entirely inward, causing such unbearable pain that the person ends up in the ER?
That brings us to borderline personality disorder, or BPD. The suffering in severe BPD is immense, particularly regarding chronic suicidality and self-harm.
The mechanics of BPD are incredibly intense. It's marked by an unstable sense of self and chronic, terrifying feelings of emptiness. This is usually triggered by an overwhelming fear of abandonment. If a partner doesn't text back in 10 minutes, the person with BPD might spiral into absolute panic, convinced they are being thrown away.
And Kernberg noted they often use primitive defense mechanisms like splitting. Splitting is a cognitive failure to integrate the good and bad qualities of a person. The brain literally splits them into absolutes.
So they might idolize their therapist 1 week, thinking this person is a flawless savior. But if the therapist is 5 minutes late to the next session, the splitting mechanism flips.
Instantly.
Suddenly, the therapist is viewed as an evil, malicious enemy who is intentionally trying to hurt them. There is no middle ground.
We also need to correct a few major diagnostic misconceptions here, too.
Definitely.
First, BPD is entirely unrelated to bipolar disorder, even though they both start with a B and involve major mood shifts.
Right, that confuses a lot of people.
Bipolar mood episodes last for days or weeks, and they are driven by internal brain chemistry. BPD mood shifts can happen within minutes or hours, and they're almost always highly reactive to interpersonal triggers in the environment.
Another crucial distinction from our sources is the newer ICD-11 diagnosis of complex PTSD. CPTSD captures trauma-driven emotional dysregulation and severe relational difficulty.
Yes.
It overlaps so heavily with borderline symptoms that BPD is frequently misdiagnosed when CPTSD would actually be the far more accurate label.
And getting the label right matters tremendously because of the intense stigma attached to BPD. There is a well-documented clinical bias where the BPD diagnosis is applied disproportionately to women.
And it is frequently weaponized by the medical system itself.
Unbelievably so.
The sources note how hospital staff sometimes use the label dismissively. When these patients show up in crisis, they are sometimes treated as just difficult or attention-seeking, rather than being treated as individuals with a genuine, often severely trauma-linked condition.
Which is why the story of Marshall Linehan is one of the most remarkable breakthroughs in modern psychiatric history.
I love this story. Marsha Linehan is a psychologist who, in the early 1990s, developed dialectical behavior therapy, or DBT. She invented it specifically because existing psychoanalytic treatments were chronically failing people with severe BPD.
Therapy was just making them worse.
Exactly. But the breakthrough wasn't just the therapy, it was the hidden origin of it.
Right. In 2011, after becoming the world's leading expert on borderline personality disorder, Linehan publicly disclosed in the New York Times that as a teenager, she had been hospitalized for over 2 years in a locked psychiatric ward.
Wow.
She had been dealing with severe symptoms consistent with what we now call BPD, including repeated suicide attempts and extreme self-harm.
She literally built the exact treatment that she wished had existed to save her younger self.
Incredible.
She realized you couldn't just analyze the pain, you had to teach the brain new skills. She combined radical acceptance and emotional validation with hard, practical behavioral change tactics.
And it worked. DBT is now the gold standard for reducing suicidality in these patients. This raises an important question for the field, though.
Which is?
For decades, society and psychiatry assumed that an axis terrace personality disorder was a life sentence. Like, if it's your personality, how can it possibly change? But Linehan's work with DBT proves definitively that enduring does not mean untreatable.
It's hard work, it's slow work, but it is entirely possible to shift the mechanics of these patterns.
Absolutely.
So why does all of this matter to you listening right now? It matters because these enduring patterns shape the most consequential relationships in your life. Marriages, parent-child bonds, workplaces.
When you understand the mechanics of egosyntonic traits, you start to understand why certain relational conflicts just repeat endlessly and resist change.
Right.
It's also vital in the legal system. Courts constantly wrestle with these diagnoses in custody battles and sentencing, trying to determine culpability. Though it's worth noting that a personality disorder rarely negates a person's fundamental legal understanding of right and wrong.
And on a practical positive note, the emotion regulation skills developed in DBT for the most severe psychiatric crises have actually moved out of the clinical realm.
Oh, yeah.
They are now taught as mainstream self-help in corporate workplaces and middle schools, helping everyday people manage stress.
Let's recap the core takeaways from our sources.
So what does this all mean?
First, to be a true disorder, a pattern must cause pervasive, inflexible impairment. Second, the egosyntonic hurdle, the fact that the person often feels this is just who they are, makes these conditions uniquely difficult to recognize and treat.
Third, the 10 fixed categories we all know from pop culture are dying out, being replaced by fluid, dimensional severity models like the WHO's ICD-11.
Yep.
Fourth, there is a massive distinction between behavioral diagnoses like ASPD and narrower trait constructs like psychopathy. And finally, interventions like DBT prove that fundamental change is absolutely possible.
It is a profoundly hopeful scientific shift for a field that has historically been incredibly pessimistic.
But I want to leave you with one final, slightly provocative thought to chew on.
Lay it on me.
We've talked extensively about how the latest medical manuals, like the ICD-11, now view personality disorders not as distinct alien diseases, but just as extreme dimensional variations of normal human traits, the Big Five.
Right.
And we know that the person experiencing them often feels those traits are deeply egosyntonic. It's their identity.
The glued-on glasses.
Yes, the glued-on glasses. So if a trait is intrinsically tied to a person's core sense of self, at what point does treating a personality disorder cross the line into socially engineered personality modification?
Oh, wow.
If therapy successfully reshapes the very foundational traits, the grandiosity, the detachment, the intense emotionality that makes someone recognizably them, just so they fit more comfortably into society's expectations, are they actually cured of an illness?
That's a huge question.
Or have we just systematically trained them to be a fundamentally different person?
It is a question that cuts right to the heart of what it means to have a self.
Something to think about the next time you see someone diagnosing their ex in a 60-second video. Thanks for joining us on this deep dive into the source material. We'll catch you next time.